Good evening, everyone. Thank you so much for taking the time to join us for tonight's presentation on safety profile of 2.5% interarticular polyacrylamide in equine and canine patients. Before we get into tonight's discussion and we introduce you to the amazing group of panelists, we have a few housekeeping items. On the bottom of your screen, you will see a Q&A dialog box. Please feel free to enter your questions as they come to mind during tonight's discussion, and we will answer them throughout the discussion as well as the end of tonight. CE certificates will be awarded at the end of day tomorrow for those of you who are able to stay throughout tonight's presentation. Tonight, our host and moderator is Dr. J.D. Conway, who's the Director of Technical Services at Kentura Vet. So, Dr. Conway, without further ado, I'll let you take it from here.
Thank you, Rachel. Thanks, everybody, for joining us tonight from all over the world, probably. We appreciate it greatly. Yes, as Rachel mentioned, we're going to talk about the safety of 2.5% arthromid in horses and dogs. And we've got some great people here to talk through this, including Dr. Jason Lowe, the Chief Veterinary Officer at Kentura, and Dr. Matt Brunke, who is at the Veterinary Referral Associates outside of Maryland. Dr. Brunke is boarded in sports medicine and is also on the advisory panel with Kentura, but both highly regarded, very informed on arthromid, been using the gel for a long, long time. And so welcome to you both.
Thank you, Jaden.
Yeah, happy to be here tonight.
Perfect. I think the plan tonight for everyone out there with the safety discussion is two, maybe threefold, is to talk about canine experience, what that looks like from a clinical perspective as far as safety. And I think that gets into some of the research that Matt's doing. Along with that is to look at the equine research that's been done across the world with different veterinarians, dive into some of the histology studies Dr. Lowe was a part of, address some of the questions that folks have out there that may be whether it's the work that we did within the synovial membrane or neurotoxicity or other things. And then I encourage everyone that's on the call, on the presentation tonight, the call, to enter their questions as we go if they have anything. Happy to stop and answer those as well. It's meant to be informative for you guys also. So I just want to talk about this, and Jason can jump in too, is that a lot of people think arthromid's pretty new and maybe it's novel to some of you guys, but it's been around for a long time, at least 25 years as far as a product and what they've been doing. And it's been rolled out all over the world. Global adoption, as you can see in that mid to 2020 to 2023 period. And now we're kind of in this phase of One Health. We started looking at it from the human perspective. We've done a big study at CSU using the carpal chip model. Previously we've done clinical validation. And so what that looks like for you guys is we have a lot of safety data implied in all of those studies, and we can look into each one. But as we break it down through the era, I think anytime we start to look at a new product, in this case, a new device, arthromid, we start in the worst case scenarios, those end stage OA cases, and then we start to shift to early stage because we get a little bit better understanding of the mode of action. And we might speak to that a little bit today, but I wanted to provide some evidence that it really has been a foundational treatment for the synovial membrane going way back. So I think that's a good starting point. But to shift back to Matt and the canine perspective, I know, Matt, you've worked over the last couple of years using arthromid and presented this work at the ACVS Summit this year or last year, late last year. What do you want to tell us here as far as safety within this with population and owner dogs?
Yeah, absolutely, JD. Thanks. Like I said, I'm on the advisory board, but I started by using it. I started using arthromid in dogs now over 3 years ago. Have used over 2,000 vials to date. And as a practitioner, first and foremost, I can tell you out of all the vials I've used, I had to report one potential adverse event, which we did. And I did that in a pug that my anesthesiologist told me, you get one chance to anesthetize this thing because it's a fat pug and it's a mess of a joint and a mess of a respiratory system. And what I did was I pushed the dose probably a little too high. The dog was sore for like 4 or 5 days. It was fully reported, but that's my only adverse event in 2,000 vials used. But beyond just that anecdotal stuff, we did a multicentric retrospective client survey that actually is now fully published open access in JAVMA if anybody wants it. Um, and we did this and said, hey, if you've used Arthrimid in your dog's joints, we fill out these questions. We know the limitations of client survey stuff, but it's a great starting point. And we had with that we had no real adverse events. Nothing serious, of course, right? About 10% of them presented as transiently sore for 24 to 72 hours, which fits with the article on the canine side by Miller et al. That reports about a 15% soreness rate in therapeutic joint injections, regardless of injectate. And then what we also looked at was the prospective study that we're just wrapped up and we're submitting soon for peer review. But when we looked at that data from a canine safety perspective, we found that we had one dog that was sore. One dog developed some bruising at the elbow injection site around day 14, which I think is the next slide. And the we did before and after CBCs and chems at day 0 and day 84 on those dogs. And one dog had a increased set of renal values on day 84, but was actually found to have some congenital kidney abnormalities on ultrasound. So going back to the retrospective, trying to cover these a lot, we had 100 clients representing 150 joints injected, which shows you that most of the time we're doing bilaterals. And in dogs, the vast majority of these are elbows, right? So that's where the data's been. And with this, from a safety perspective, like I said, 10% of them were transiently sore. But what was also interesting was 90% of clients indicated they would use it again if they were recommended to do it. So even with some experiencing soreness, it didn't really avert anyone from doing it long term if needed.
So Matt, can I just ask there, what sort of like how old was your pug and sort of can you remember sort of the average age of the dogs in your study there?
Yeah. And I think we'll have a little bit more on the prospective stuff in the next slide, but the pug was this like 9 or 10 year old
Hmm.
BCS of 12 out of 9, every respiratory component of a pug. Um, and so that was early on. It was about after I'd been using it a year, so still early on for me. And we're still looking a lot at dose, Jason, and with that, I didn't want to sedate the dog twice. Like I said, my anesthesiologist gave me one chance um,
Yeah,
with this. And so we nudged the dose at the higher end of the dose range for that size dog. And I think that, as we talked about as a team when we reported, that's the most likely problem was that we just put a little bit more in. But once it got absorbed, the dog actually did great. And that dog's now out 2 years, and that client's a regular client with his other dogs, and he hasn't told me his dog is sore or painful. So, in a looking forward out of a negative situation, that dog's also really comfortable 2 years later, and we haven't had to re-inject.
yeah. Yeah, it's quite interesting, isn't it? And I think when you look at some of the human data too, because I mean those numbers are quite high, I guess, compared to what we'd expect or see in equine medicine. And I always sort of wonder in horses if a lot of them aren't reported because the veterinarian we just sort of deal with it. We're commonly injecting joints. And I wonder again, we're injecting younger athletes, and maybe we get fewer complications, but some of the reported uh, outcomes in humans as high as 30%, because obviously humans can talk, right? And then when they
Hmm.
get this sort of thick, viscous gel injected into their joint, they go, yeah, I can feel that. Um, and also, I think, older age group, more chronic disease, and if that's sort of the dogs that you're treating as well. But it's just, yeah, interesting.
Oh, absolutely, Jason. Like I've tracked out my data now for about 5 years, and I inject over 400 dog joints a year. And knock on wood, I have not had one dog joint go septic on me after we've injected it. I'm going to burn myself, right? Everybody on this call, we all know we have a couple. Um, but I also consider in my world where most of what I inject, not only in the survey that we did, but I track out all the joints I've ever injected, close to 90% of them are elbows. That's our sticking point in canine. I always do them with a medial approach because that's how I was taught. But by also avoiding the lateral approach, because to me, if these older dogs have calluses, you're just asking, in my opinion, to track bacteria from that really thick pachyderm-like skin around a callus. So I think just being really smart about how we pick out our patients, that we prep our areas. I'll go a little bold here, at least on the canine side. Jason, you can speak to the equine, but on like these pit bull type dogs, I don't have my team shave the medial elbow. Because if there's not that much hair there to begin with, I also don't want these dogs getting clipper burn or things like that. Um,
Yeah, that's the same in horses, and there's some good studies out there showing that. I know sometimes, when I was working in the UK, and especially in the winter, when you get quite long hair coats, if you're worried about contamination, I might shave them, but try and not get too close. There's various ideas, I guess, around clippers versus shaving versus just using some scissors. But to me, it's about the prep and it's about contact time, right? So it's getting a good technique, using the right concentrations of Hipposcrub because chlorhexadine's been shown to be the best for for sterilizing that skin. And then, yeah, definitely about contact time. And I think sometimes if people rush that, they can get into trouble. Uh, and sometimes if you're under time pressures, especially in equine, you just have to slow down and go back to the start. And if you get a contamination breakdown, that's definitely your biggest issue.
Yeah.
yeah, I'd agree. It was interesting. I think there's a couple. Hopefully, there's come some surgeons on this call. There's a paper in Vet Surge a couple of years ago, which by a couple is probably now 10, that compared a number 40 blade versus a number 10 blade on a set of clippers, for surgical sites. And they found not the 40 blade that we all use, but the 10 blade actually had less skin irritation, less complications. So I'm not saying we shouldn't be shaving, but we need to be really aware of how we're prepping sites and
Yeah.
thinking about these. Um, but again, like looking at the canine prospective stuff, again, from a safety perspective, and we've now tracked all these dogs out. So 18 out of 18 dogs made it to day 90. The two that dropped out, I'll talk about in a minute. But again, from a safety perspective, on those 18, one of them had some transient joint soreness. One had some joint bruising that didn't show up till day 14, but resolved by day 28. And yes, two of the dogs did not make it out to the full 12 months. Um, One dog dropped out right at day 91, due to increased pain. Um, Interestingly enough, there was a little bit of miscommunication, um, where we said, "Hey, you can kind of go back to normal." And in our world of small animal, most things aren't that active. Um, Mom thought normal meant normal, so she took the German Shepherd with really bad elbow arthritis behind her on the horse for a 3 hour hack. And shockingly, the dog was screamingly painful because it hadn't done that in a year. So we had to wash that one out of the study. And then the other dog that didn't make it in the study was an older dog who wound up developing neoplasia, not even in the affected limb, in the injected limb, but unfortunately, that dog, as a comorbidity, had to be sadly euthanized and dropped out of the study.
That's pretty impressive, isn't it, to get that number through to 12 months? Because often it's the hardest thing in clinical trials. You get big dropout rates for various reasons, right? So,
Yeah. And this was what was really kind of impressive, surprised me, because again, like tracking out my data, the average age of a dog I inject is almost 10 and a half years old. As opposed to equine, where you guys are finding joint problems early in life, we haven't been in Solano historically. But the 12-month cohort here actually had an average age of 7.2 years. They're big dogs, 32 kigs on average. Interestingly, we didn't intend it, but we got an even split of 9 spayed females and 9 neutered males. And probably to no one's shock on this call, 5 Goldens, 4 Labs, and 9 others. Um, so really a lot here on looking at these dogs, intently seeing them at 8 different time points over this year-long study and no adverse events really of major significance. And I really appreciate that having that transparency with everyone about mild, moderate, and severe AEs. I think it needs to be out there. So here it is.
Yeah, we will talk about that towards a little later. Just kind of to be transparent, like you said, with Jason and I, from a company perspective, what that looks like overall. We did have a question come in, Matt, from somebody just asking about using it in hips. Have you used it in hip joints, and what does that look like for you? And needle placement, needle size, and that kind of thing. Maybe that's
Yeah,
a key
absolutely.
question as well.
Great question. We've used it in a bunch of hips. We've got some other stuff that we'll be looking at, not an official written up study yet. But in hips, again, thinking like Labrador Shepherd size type dog, either using a 22 gauge 1.5 inch or a 22 gauge 2 inch spinal needle. Um, I do all my joint injections predominantly off of anatomical landmarks. Full credit to my friend and resident mate Chris Fry at Cornell. If anybody wants to get into ultrasound guided joint injections, Chris is publishing everything through JAVMA. He even did JAVMA technical tutorial videos, which are free and open access that you can actually see how he does them on cadavers. So I've injected I have to go back and look exactly, but a number of dogs with arthromid in their hips, um, seeming to get about the same type of results as we are with elbows. I think of, a lot of this with hips is they're fibrotic. We're catching these late in their disease process. They're not these big inflamed joints like sometimes a stifle can be or other joints like that. So I've been really finding it helpful. Don't have exact numbers on it, but also haven't had any negatives there either, other than perhaps not getting as much of a response as we would want in some of these end stage ones. But it's been very helpful for my patients.
why do you think you're picking them up sort of late like that? Because you obviously these dogs have been screened or they're just missing that screening process.
Yeah, small animal is a little bit different world than equine. I always joke that canine's about 2 generations behind sometimes. You guys have been injecting joints, uh, what, since the 1960s? Not you, Jason, but equine's been doing it for a long time.
Yeah.
There's a big knowledge gap there, but sometimes for pet dogs, it's, oh, now it can't go up the stairs, it can't go outside, has it stops and lays down on walks. So we're seeing really hip dysplasia really has a bimodal age distribution. You either see it in that 4 to 10 month range where they're absolutely crippled. And those are usually Bernese mountain dogs, and they usually hopefully get a hip replacement and they're cured. Or we're catching them around ages 5 through 9, where they're really fibrotic, really painful, end stage, severely arthritic joints, and now trying to do our best to manage those.
I noticed it was bilateral elbows in this study, this prospective study, single arm. Common for you guys, and maybe you've mentioned this earlier, but and then that kind of brings you back to the hip deal. Is that common to do bilateral hips for you, Matt?
Yeah, absolutely, JD. I mean, there's an elbow study out of the UK that I think something like 61% of elbow dysplasia is bilateral, but just may not be at the same progression, left elbow versus right. And I think those are very similar numbers to what we see in hip dysplasia. So yeah, for me, if both hips hurt, both joints hurt, I'm going to go ahead and treat both on the same day to try to get that patient the level of improvement we need. Um, because also too, as opposed to equine, we're standing sedation, right? We're having to make sure these patients are at least heavily sedated, or if not general anesthesia in some severe comorbidity cases. So we need to do our best to get them as comfortable as we can. Which
Yeah,
kind of
it's a
leads
good.
in, I guess I can talk about this, the slides up. Everybody, a common question I start to ask, and I asked our equine colleagues, was, well, if we want two different mechanisms of action, if we want more of a potent anti-inflammatory, like a steroid or PRP, but we only get that one chance to really anesthetize, we want to combine it with arthritis, can we do that? So between myself and the team out at Red Sage Veterinary Partners in Fort Collins, we're actually in the middle of a retrospective multicentric review of patients, dog patients, getting arthrimid plus something else in the same joint on the same day. And that we hopefully we'll have ready as an abstract for ACVS this coming year.
That's
That's really
fantastic.
cool.
That's a really good study. That, and I think it, understanding what we know about the gel, it's probably something we're questioned on quite a lot. And does it interfere with other medications? Is there risk of combining stuff? And when you really understand the technology, I guess, and the chemistry behind the molecule, we you start to realize it's fully permeable to organic molecules. It's quite an open structure. It's 97.5% water. So there's very only 2.5% dry matter of the polyacrylamide backbone through that. So without preempting the results of your study, we certainly don't see or expect challenges with that. But JD, I see you've just pulled up that slide, so why don't you talk to that?
Yeah, I think it kind of leads into this. You're looking at it from a concurrent use of or whether it's orthobiologics or another corticosteroid. We had the same question as the company, and so we investigated with Dr. Whitaker and Salado at Salado Equine Medical Center down there, and he did a tolerability study using 6 milligrams of betamethasone just to see, what are those horses? What are they going to look like? Are we going to see any issues with them? And we didn't in that cohort of 10 healthy horses. They maintained their same level as far and these were just various types, and but there was no adverse events, no issues at all. So we actually um, it was a good study, and it was a good something good for us to see, at least on the equine side, because we do use concomitant combined therapies all the time. Not usually adding antibiotics in the injections per se, but commonly orthobiologics or corticosteroids, I would say. And so we wanted to see if it was okay, to your point, Jason, with Arthur and I think this says it's okay. Is it recommended? No, I think we think no Arthur works alone and does a really good job, but you have those situations where you want to address the inflammation right away, and I think that's the point there. Got a few more questions here. I'm going to jump into a couple of them. Let's see. I've got them coming in both directions on the the chat and the other, so I'll just kind of go in order and see what we see here. From the small animal side, do many of these patients only require a single injection? And if repeat doses are often required, then when do you find subsequent injections are typically needed after the first treatment?
Oh, Jason, do you want to comment on that at all, or do you want me to take that a bit?
I'll be interested in your clinical experience. I know from the data I've been looking at from Dr. Keller in Germany, there's sort of around 10 to 15% of dogs are requiring a second treatment, and on average, that's about 12 months after the first treatment.
Hmm.
But so obviously that's showing that around 70, 80% of these dogs are responding long term to one therapy. I think you can probably equate that across the human side as well, where we're seeing up to 5-year efficacy from one treatment, which is quite impressive, which I think sort of talks to some of the new data we've got from the osteochondral fragment model at Colorado State that JD alluded to before, that's showing that sort of mechanical restoration of the synovium capsule, essentially helping with downstream effects on the cartilage and giving us these long-term outcome results. So obviously there's lots of variables in that. There's genetic variables. There's how the animal, patient, dog, horse, no matter what, is managed, is going to affect the progression of the disease, the severity of degree of disease when you intervene in it. And like you say, Matt, I think with equine, we're way more proactive, but saying that these are big animals going fast, and we've shown in some thoroughbred racing data, sort of 7 to 8 months for repeat therapy, but out to sometimes 2, 3, even 4 years in some of the other sport disciplines. So I don't know, how does that equate to your clinical experience?
Yeah, I think, Dr. Keller's done some great work in Germany with, I think maybe the EU pet dog owners are just more astute, or there's just a difference sometimes because I find, like I said, I'm injecting so many older dogs that we're dealing with more end stage disease. Um, so I'm really looking at going, we may need to re-inject in a year, but if we can get a higher dose in there, because dose is still something we're kind of looking at, as you say, on the human side, the in the original human studies, it was 3 mLs in each knee, and then they expanded it up to 6, and that's that 6 ml cohort that's out to 5 years. So we're still learning a lot on that, which is why I think we start looking at, can we use concurrent things like PRP or steroid? Um, so I'm looking at going probably in the original groups when I was using it, I was finding I was getting about 9 months. Now, also, the average body condition score of a dog I inject is a 7 out of 9. So that is a heavy factor, bad pun intended, as well to look at the whole patient. Um, so I started off on the lower end of the dosing, and then again trying to go back to, gee, if I can do a higher dose, it costs a little bit more up front, but if we're going to get 12 or even 12 months or longer, then to me that was starting to become a factor because I don't want to have to re-sedate. And in small animal world, what I'm always looking at with these patients is we're not trying to get them back necessarily to the racetrack or to the show ring or things like that. So I'm looking at going, what can I do as a near instant gratification to get them feeling better for a long term while we work on getting that BCS from, we all would like it to get to a 5, but hey, if we at least get it lower, it's a little bit better, and we get that dog stronger. Um, I
Yeah,
do see
I
another
think
one kind of related to that. Most of the time, if I'm doing steroids with my Arthromed, it's usually triamcinolone because that's the least chondrotoxic in canines. Um, some of these end stage joints, we might be using methylpred, but predominantly it's triamcinolone, but no
yeah, I think
antibiotics.
you make lots of really good points there, and it's interesting the human data when you look at one of the predictive outcomes of a responder versus non-responder is your quadriceps muscle strength going into it. into therapy, and it's absolutely about the rehabilitation. And I think that's again where we see, great results in horses, because horses are regularly exercised and they're in that routine. So sort of patient compliance is really high and really easy to sort of get where. And as you were saying, Dr. Keller's work in Germany, average age just over 5 years, very much a sporting dog cohort. So early detection, good maintenance, fitter, younger animals with retained physical characteristics. Because I think treating the joint is definitely always 50% of it. Just like surgery, it's your rehabilitation that gives you the extra 50% of results. So
Absolutely.
good points.
One of the questions that came through, not to shift too much, but I think it relates to a couple of things. What happens if we inject Arthromed in some of these smaller joints that are hard to get into? Maybe it's a carpus or something on a canine, or it's lower hocks and equine, and you inject, and you get a little bit outside the joint, and a little bit leaches out or leaks out as you're just because the space is so tight. What do we see? To swelling, bumps, or reaction or whatnot? What's your guys' experience there with, like, smaller, tighter spaces and leaking out? We've all had that, and
Right.
injecting a horse, you go in there and some comes out as you're pulling your needle out, and you just are like, well, hopefully we
Yeah.
got most of it in there. But
Well,
any thoughts? Because there was a question.
yeah, I think on my side, clinically, like I want to make sure I got the dose that I want into that joint, um, which kind of goes to, can you put in too much? Now I really have a better feel of when that plunger starts to give me some kickback is when I know I'm done. If I'm trying to get a higher dose in, um, knowing that we can use the same exact gel in human faces, and urethral tissue in humans, um, I know I don't really have, from a clinician perspective, I don't have a worry about getting it extra articular, because it can be a bulking agent for the urethral sphincter, and for the human face, which we can get into it if we have time. So it's still inert, so I'm not worried about that. I just want to make sure I got my dose in the joint. So I'm just really carefully watching the integers on the syringe to know where I kind of have that to be. And one thing that's helped me, which I know is totally different from equine, is I love lure lock syringes, so that I get that good tight seal and I know I get stuff out. And the equine guys always chuckle with me on this one. Just a difference in our patients. But that's what I'm looking at. I'm not worried about it outside. I just want to make sure I got my dose right in the joint where I want it to be.
Yeah, I completely agree. There's zero safety concerns to get it outside the joint, except, like you say, it's not going to work there. You just end up with a very expensive lump, or soft tissue swelling, which will probably sit around for quite some time. I think it's more, like you say, Matt, I agree. I think it's more about getting the right dose into the joint, and perhaps we could sort of dive into that a little bit deeper. And I also think that it's about getting it intrasynovial. And I think if you inject it periarticular, I think you do see more challenges with that. Maybe some edema as you get that sort of response to the gel, and that might be a bit more disconcerting for the owner, especially with some of the, well, I think, horses and dogs really. So I think I highly encourage ultrasound guidance. I think especially around stifle injections, the medial femorotibial joint is often hard. It depends how the horse is standing as to how exposed that joint is. You can go off your landmarks, but it always surprises me. Sometimes when you actually put the scanner on, you still got to move where you thought you were going to put your needle to hit that space. I also think with fetlocks in horses, I much prefer the lateral approach through the lateral collateral ligament to get it nice and clean into the synovial cavity. And compared with the palmar or plantar approach, where I think you have a much higher chance of getting some synovium, synovial membrane sort of stuck in the end of the needle or something. And I think with the dose rate, yeah, it brings up a really interesting stuff, and it's something we're looking at a lot more now that we've got a better understanding of exactly how the product is working downstream on the sort of genetic expression and moderating that inflammatory response in the gel. So I think there is dose dependent response. The more you give, the better, but without overloading the joint. And I think that's more related to the sort of chronicity or severity of disease. And we're certainly encouraging people, if we think it's chronic severe disease, give as much as you can get into that joint. Whereas sort of more acute cases, lower doses seem to be just as effective.
Well,
Yeah.
and to go back to small joints real quick,
Okay.
um, I've dropped it into some proximal and distal interphalangeal joints on dogs. So that can be done. I have pushed it through a 25 gauge needle and gotten it into those joints because we get those border collies that just break their toes, basically. Their carpi and elbows and shoulders may be fine, but their toes are really in a bad way. So I've done that. I've done metacarpophalangeal. I've done metatarsophalangeal with the gel through a small needle. And I've done a bunch of cats, including some funky Scottish fold cats and stuff. So, it can be done. It's just a steady hand, a great nursing team, a great anesthetic plane. Um, and so I've been, once I know I've got that fluid, that joint fluid out, I'm just very stable and just very deliberate on making sure I've got a good seal on the syringe and push. And if everybody, for me, Jason, JD, I don't know how you guys see this in equine. If I am doing concurrent therapies, I find it's easier after pulling out the fluid, the joint fluid. I'll put in the aqueous product first, be it the steroid, the PRP, right? And then I'll follow it with the viscous arthramid, just because I feel like I can get the aqueous stuff in, and then if anything's clogging in the needle, at least I've got all my arthramid in. I don't have to try to do the aqueous, but I'm also doing mostly 22 gauge needles is probably the largest needle I'll use. And I don't really use 20s much even more in dogs. Are you guys finding similar or different? How are you approaching that?
I think it's very similar. Most are, at least on this side of the pond, most are using 22 and 20 gauge needles in horses and injecting the aqueous. So whatever that is, whether it's PRP, Prostride, IRAP or whatnot, and then Arthromed, if they're using combination therapy. And there's some that, if they're going to just use Arthromed alone, and they may put a teeny bit of carbocaine in there to make sure that if they all they want, if you've got an animal that's really it just needs Arthromed and it's we're not going to be putting any combination of a product in there based on the pathology. They may put a little carbocaine, make sure they're in the joint space, and then follow it with Arthromed. And so 22, yeah, is very
Yeah,
common.
I think it checks your needle placement because it shouldn't if it if the aqueous injects quite easily through a narrow gauge needle, you're in the right space, and you definitely won't get arthramid into soft tissues through a narrow gauge needle because it's just too viscous, it won't inject in. So you've checked that you're in the synovial cavity, like you say, with whatever you're going to use, or even some saline or carbocaine or pivocaine. And then, yeah, add the arthramid in. I guess my only caveat, I always get nervous because it happened to me once that the horse kicked out with a fine gauge needle and it broke the needle off at the hub and left the point of the needle embedded in the skin. So it's always a risk.
So it didn't happen to me, but it happened to one of my colleagues when I was we had that with a dog who wasn't on the best plane of anesthesia, and the needle broke off and they had to go in and do an arthrotomy. So what I teach my residents, my interns, my students is your non-dominant hand is on the hub of that needle at all times. And because if the dog wakes up and you have to back yourself away from the table, I'd rather have you take the whole needle with you than
Mhm.
than not.
Yeah.
That's a
Yeah.
safety discussion right there.
Yep, I agree.
I think there's more places that are, you're prone to have that happen for sure. And I've been close a time or two, and thank thank God I hadn't had that happen yet. But I did want to throw this slide up here with Dr. Tenenbaum did a big review of the gel, and he also included a safety analysis, just looking at, it's 10 years of use across the globe, and a low percentage of adverse events, and I think it was down to 0.004 in this paper, but and these were mostly studies that were done going all the way back to 2014. And his review, I think, was published in 2024. So something to note there for you guys, independent study. But moving forward, I think it's important to understand some of the misnomers about the gel. We often hear this term macrophage response, of how it works, and I guess some people understand it, some don't. Is this the immune system that's doing this? This foreign body like response, or what is that? And so maybe Jason, you can clarify that since this was your study.
Yeah, probably fair enough. Um, yeah, look, I think it is. I think it's there's probably is some misunderstanding around what we were saying in this study. The fact is that when you inject it into the joint, and this happens with any injectate, and Matt, you sort of mentioned that before. With any injectate we inject into a joint, we get the body responds to it, right? Because
Mhm.
it's abnormal. But what we showed in this study, we took samples, serosynovial samples at 14 days, 42 days, and at 90 days. And we also did histology in the horses again at 42, 40, 14, 42, and 90 days. And what we showed is that there's a macrophage response to the gel. So by definition, that is inflammatory and it's a foreign body response. But what's really important to understand is that at no time point did that go above normal laboratory limits. Okay, so this is a low level. The macrophages come in to have a look. They peaked at the 14-day sample. By 42 days, they were regressing again. And by 90 days, everything was normal. So this is transient. They come in, they have a look, they go away again. Nothing to see here. So that's really the crux of this paper. And it was also to say that they're macrophages and to emphasize that because there was the Christensen work, which was published in 2014, sort of showed these histology slides that were really interpreted by some people and some surgeons as fibrosis, as hyperplasia, as hypertrophy of the synovial membrane, which is counterintuitive, isn't it, to what I guess we expect when we're trying to treat animals. We're always trying to get them back to normal or what's perceived as normal. So, but what macrophages do, and we have synovial tissue macrophages, the macrophage population is actually starts to, the synovial cells, the type A, B, and these sort of in between type C synoviocytes that are producing your synovial fluid, that are dealing with inflammation, that are dealing with cartilage breakdown products, bone fragments, whatever happens in that joint, it's macrophages that deal with that. And they get recruited in out of the hemopoietic system as they move into the synovial space and sit in the synovium to deal with all this stuff, because that's what the synovial membrane is doing, is acting as a semi-permeable barrier essentially between the joint space and the body. And joints aren't sterile either, right? You get bacteria will head into these places, and we see that a lot in young animals and foals and things with umbilical infections, and those bacteria will end up in the joint and cause joint ill. Um, so I guess, yeah, that was really that there's no fibrosis, there's no mineralization, there's no granuloma. So all those were really important to understand and sort of clarify between the earlier Christensen paper, and then we put this paper out again to show, I guess, the repeatability in the data. And I think that's what always strikes me with all of the publications, and as Disease Nibar's review article you put up before, JD, that the data is repeatable. And that to me gives me a lot of heart, because we always understand in veterinary medicine it's hard to get big numbers. We don't get 20, 30,000s like they do in the human data. So we're getting as big a numbers as we can, but we get repeatability. It gives you a lot of confidence. So.
That's cool.
Do you think those are the key points that I just wanted to sort of get across in that? And like I say, by definition, it's foreign body response. That's actually the term and reference term that we put into the article out of human medicine. But it's really just I say it's inconsequential. There's nothing to be concerned about. It's perfectly normal.
Yeah, it's basically what the macrophages are saying. There's nothing here. It's a gel we like. They see it as their jobs to see things from the immune system perspective, as friend or foe. They present their antigen presenting cells most, through the immune system. And so, is this something they want to attack and do something with, or are they going to leave it alone and let it reside and do its job? And we see that with
Yeah,
other, injectables or implants or whatnot. So throughout,
100%. And just none of them have done this study, right? No PRPs, IRAPs have actually looked at this and done this, and the alpha 2 macroglobulins, yeah, none of them have published on this. So I'm,
yeah,
I'm sure
yeah,
they will do it. I'm sure that if you inject saline, you would see exactly the same response. So,
I'm guessing you would too. One thing that popped up, that what about lasering or shockwave, with Arthurman? I can tell you at least in our IFU information for use, we don't recommend it within 4 to 6 weeks, depending on what modality you're using. And has that been tested? Some of that information, and Jason and I all kind of can speak to that, but some of that information is coming from the shockwave manufacturers, or what they told us to a certain degree, some of their veterinary services, but I don't necessarily think that's fully the case. Um, but you guys, what do you think?
do you have what's your recommendations, Matt?
Yeah, I mean, I lean on you guys for this one. So what came from Meg Green and the technical services team when I started with this was to avoid those. And I think, to be honest, that I liked doing that when I first started using the product, because I could change one variable in the equation at a time. I sedated, I pulled out joint fluid, I injected Arthromid alone early on, right? Um, and even now, I still do a lot of Arthromid alone. But if I just put in Arthromid and the dog got better, now also I don't need to be lasering or shockwaving that. So I can just see if my experiment, right, as a clinical scientist, if I did this, am I getting the same results that other folks were getting on paper or that way? It also helped in long-term incline compliance as we started to use it more, because now, hey, they're not coming in as often if we're not doing laser, they're saving time. And then when we get them into the rehab aspects of it, which I'll do early in the process, 2, 4 weeks post injection, my rehab technician team, they'll use shockwave and laser on the sore muscles, the other areas of the body, treating the patient as a whole. But they're finding that the joints are comfortable. So they're like, well, we were doing shockwave for joint comfort. The joints are comfortable. We don't need to be doing that. So they're more efficient in their time and able to focus more on exercise and the patient as a whole.
Yeah, I really like that approach, because again, to me, yeah, it comes back to management, right? We manage these cases and patients through, and I think that concept of I can chuck everything at them and cure them, it's not how it works. And I think the data that we've shown in some of our studies looking at the response rates to therapy at 2, 4, 6 weeks, you sort of get this maximum therapeutic response somewhere between 2 to 4 weeks. So you should be waiting at least till 6 weeks before you assess the clinical outcome, and then introduce some of your other modalities to treat the other areas, or reassess your diagnosis. Go back to the drawing board. So yeah, I agree. I think physiologically, again, we know that the gel integrates. It takes 10 to 14 days to do that. The new data from CSU is showing this sort of alteration in the inflammatory response at 2 weeks after integration of the gel into the membrane. So again, everything's pointing to wait at least 2 to 4 weeks to let the gel do its thing. You've put a therapy into this animal, let it do its job, and then look at some other modalities if you think you've still got some other stuff to address.
We often get asked, and this is a misnomer I think that's out there. Is this gel, because it's a polyacrylamide and we know acrylamides have some toxicity? Is this neurotoxic? And you want to answer that, Jason, but why
Yeah,
this was done?
yeah. Again, I think it was like you say, people just looked at the word polyacrylamide, said acrylamide, and took a huge leap to say it must be neurotoxic. But although it's made from a monomeric acrylamide, this is a polyacrylamide. It doesn't break down into an acrylamide. Even if it did, it's an incredibly stable, strong molecule because of the ILX cross-linking that they do when they manufacture it at Kentura. And even if it did break down, which actually requires an immense amount of energy, physical energy, high temperatures, high pressures to actually break this gel up, to break that molecule up, it would still just break down into smaller and smaller particles of polyacrylamide. It doesn't come out to an acrylamide. There's been a number of studies now. The Aziz Nibar goat work published in 2015. This work by Walmald et al. Published last year. And there's some more work coming from CSU, from Aaron Contino and the team there, which also looked at this. So again, acrylamides cause demyelination. And so it's actually relatively easy to see that on normal histology with nerve-specific staining. And in the multiple studies done now, there's just never been any evidence of that. The company also do a lot of release specifications to ensure that there are no acrylamides floating around. I think, we've just got to put this one to bed, walk away. There's actually some of the latest studies now are looking at combining stem cells with 2.5 iPAAG, because it sort of acting as a bioscaffold to support the stem cells, and nobody would mix it there if it was cytotoxic. So I think we just got to put that one to bed, move forward, people. It's not how it works. So.
Right. Well, I know we're kind of getting short on time. I did want to jump ahead a little bit, to be transparent and get to our adverse events. We probably won't have time to go through all of this, but as we're a global company, and we monitor all of the adverse events that occur, whether it's in our human products, arthrosamid, or the animal health side with Arthromed, whether it's canine or equine. And out of over 90 some thousand syringes that were utilized in horses and dogs, there were 35 adverse events in total, that were reported to the company, 27 product related, and then 15 serious. And so we show this to be transparent so you guys can understand that it's just a really, really low adverse event rate, and kind of how we classify things. And if you've reported one or something, you've probably spoken to myself or Meg Green, but we just want to be transparent, and I think it's important to do that. But probably more so is like, what do you do when you have an adverse event, or you have a flare, and that's one of the questions in the box. So, what's the common protocol for, you injected a set of coffin joints and you got a one left and right, and you got a flare on the right side or something like that. What's your protocol typically, Jason?
Yeah, this is a great question. Obviously, if ring us if we're available, but as a veterinarian, you might be out there dealing with this. You might have a stressed client. It's a stressful situation for all of us, and we completely understand that. Obviously, infection is the number one differential. Is this a septic or a non-septic flare? And I think what we see in the septic flares is that it might be presenting sort of 7 to 14 days after the treatment. You do a synoviocentesis and you've got some neutrophils, even if you just smear that back at the clinic. Obviously, if you're out in the barn or there at the time, some systemic antibiotics, you're going to cover yourself with that. And some high doses of non-steroidal anti-inflammatories will sort of treat both as well, the septic and non-septic flares. We find a really good combination, and non-steroidals works really well in looking at, I'm sorry, I'm not familiar with the trade names that you use in America, but sort of phenylbutazone with firocoxib or paracetamol combinations seems to be best. And there was a great paper, I forget the author, I apologize, but we could share that. Looking at that, and just instead of using one, just trying to get a broader anti-inflammatory effect. I think
Yeah.
what we see in the flares, a true product flare tends to happen quite early after therapy. So I'm talking sort of 2, 3, 4, 5 days after injection. The cytology on those tends to be sort of more a monocytic or macrophage response on smears, and sitting around that sort of 30 to 50,000. Obviously, that's not an absolute number, but it sort of starts to give you an indication that, hey, maybe this hasn't got sepsis. And we tend to recommend being a little bit more cautious with those, or a little bit more conservative rather, and that just hitting the, again, systemic antibiotics, you're going to cover yourself, some non-steroidal anti-inflammatories, but try not to rush to surgeries on those. And I know, we end up getting these referred into hospitals, and I think we just sort of think, oh, well, they're infection until proven otherwise. And I know, all the results we've had that, all the studies have been done that, well, you don't culture anything bacteria out of synovial samples, and so we just treat them as infection. But the bad ones we've dealt with, I think these joints just get really wound up, and by going in and starting to do synovectomies and putting essentially, acidic or low pH antibiotics directly into the joint, like amikacin, gentamicin, some aminoglycosides, you end up with just winding up this inflammatory response and making that joint angrier and angrier. So I think obviously by that stage, be talking to us, working through it together. And as JD showed on that slide there, there's an incredibly small number of what I'd term serious adverse events, which are requiring hospitalization and intense care. But most of those resolve when they're treated properly. And again, I was with the caveat of unless there's severe underlying pathology, and the ones that we sort of haven't managed to sort out, they've got complete subchondral bone exposure, subchondral bone collapse. So they probably weren't good candidates in the first place. But yeah, that's easy in hindsight, right? We're all veterinarians and we're all doing what we do. So
Well, we kind of come to the end of our session, and I don't see any more unanswered questions, at least in the box. So I just want to say I appreciate everybody posting their questions. I know we may have not gotten to everything that was in the chat. Hopefully, we got to most things. Talked a little bit about what we see from a canine perspective, what we see from an equine perspective, showed some of the research, were transparent about adverse events, and then had some awesome panelists with Dr. Lowe and Dr. Brunke. Anything further you guys want to say, Matt or Jason?
No, just thanks very much for those that have listened in, and thanks for moderating that, JD. It's been great, and thanks for your input, Matt. It's